بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وآله وصحبه أجمعين. It is a pleasure and honor to join you today for this activity and titled the kidney disease in the International Pathology Day. Thank you for Faculty of Medicine, Sayoun University, and the team, Professor Muhammad Ashur, Professor Hussein Bakathir, Dr. Sarah, and all the team. And my talk will concentrate upon the management of renal cell carcinoma from medical oncology point of view. So as a start, we can see that the incidence of renal cell carcinoma, it is almost constitute about 90% of the kidney cancers, with almost 2 to 3% of the adult malignancies. In Hadramaut, if we refer to the cancer incidence report for Hadramaut Cancer Registry, we can see that renal cell carcinoma is not among the top 10 cancers. As risk factors, as we know all that the smoking, obesity, hypertension, and some hereditary syndromes like VHL are among the risk factors for renal cell carcinoma. And the histology, I think that my colleagues in the pathology, they will spend time discussing the different types. Just I will summarize that we have the clear cell renal cell carcinoma, which constitute about 80% with the presence of the VHL mutations. We have the papillary type, which almost comes as 10 to 15% with the two major mutations. In the type 1, we have the MET mutations, and in type 2, we have the VH mutations. Then with the best type, or the best prognosis type, which is the chromophobe, which constitute about 5%, and we have other rare types like the collecting duct. The clinical presentation, usually we call it the cancer of the internist, because usually the finding is incidental during imaging, and sometimes in less than 10% of the cases, the patient may present with some clinical manifestation like with a classical triad of hematuria, flank pain, abdominal mass. Sometimes the presentation comes as paraneoplastic syndromes like hypercalcemia, erythrocytosis, others, and some patient present with metastasis manifestation, bone pain, cuff due to pleural effusion, or lung mets, and others. We can diagnose renal cell carcinoma by the contrast-enhanced CT scan, which is the gold standard. Sometimes complementary MRI might be needed, and with complementary ultrasound. And for the biopsy, we do it for the small masses, and prior to treatment with ablation, or and as medical oncologists, if we are planning to start systemic therapy upfront, so we have to do the biopsy prior to the systemic therapy. Staging, the simple staging schedule, we can say that when the tumor 7 centimeter or less, and confined to the kidney, we call it stage 1. If it is more than 7 centimeter and confined to the kidney, this is 2. If there's a renal vein invasion or regional lymph nodes, this is stage 3, while for stage 4, for any tumors invading beyond the Girotta fascia or those with distant metastasis. What about the prognosis? The 5-year survival for stage 1 up to 95%, stage 2 up to 85%, stage 3 up to 70%, while it drops to 20% as maximum in stage 4. The treatment algorithm for renal cell carcinoma, as simplified way, the localized disease, usually we consider partial nephrectomy as gold standard approach for tumors 4 centimeter or less, that means T1A, and for unfit patient, we can consider ablation. While for those patients with tumors more than 4 centimeter, to 10, we can consider either partial or radical based on the surgical decision. And for those patients with larger tumors, we go for radical nephrectomy with some consideration of the lymphadenectomy based on the suspicion of the lymph node involvement. For those patients who have high risk for recurrence, we go for after surgery for pembrolizumab, which as adjuvant. The pembro is immune therapy, which is PD-1 inhibitor. And this is the guidelines for the adjuvant treatment for stage 2 partial nephrectomy or radical. And we have to, as category 1 recommendation, we have to consider the use of pembrolizumab for grade 4 tumors with clear cell histology plus minus sarcomatoid features, while for non-clear cell we don't use the immune therapy. Now when it comes to stage 3, again the same recommendation is applied for all the grade, for all stage 3 regardless of the other features. And that was based on the famous trial Keynote 564, which compared pembro 200 milligram IV every 3 weeks in comparison with the placebo, and it showed that there is not only a disease-free survival with significant hazard ratio and p-value, but also overall survival benefit. And we can see that in the curves, the maximum benefit was in those high-risk patients and those with metastatic disease who were treated without any more evidence of disease. We call them M1 NED, no evidence of disease. So look to the separation of the curve and those in the right side in comparison with the left side. So when it comes to the high risk and metastatic without evidence of disease, the separation of the curve is very impressive. And also the sarcomatoid patients, with those patients with sarcomatoid features, we can see that look to the right side curve, we can see the marked separation of the curve in comparison with those without sarcomatoid features. So the highest or the higher the risk, the better and the more the benefit from the pembro. So who should get adjuvant therapy? As we mentioned, those with clear cell renal cell carcinoma with pathological T3 or higher disease, those with also M1, no evidence of disease within 1 year of treatment of the metastasis. And the pembro based on this trial was approved by both the American and the European FDA and EMA. So we'll end our talk with the metastatic renal cell carcinoma. Now, we have the hot discussion and debate about the cytoreductive nephrectomy in metastatic renal cell carcinoma. And we know that RCC is an immunogenic tumor expressing multiple antigens. And the idea between the cytoreductive nephrectomy is to eliminate the immunogenic sink and to prevent the secretion of the protumoral cytokines and to limit the development of new biological clones. Historically, we have the SWAG trial, which compared cytoreductive plus interferon alpha with interferon alone. And we can see there is benefit from the combined approach, cytoreductive plus interferon, 13 months overall survival in comparison with 7.8 months for interferon alone. And they noted that the great survival benefit was observed in patient with good performance status, and that means fit patient with pulmonary only meds. Then the retrospective data by systematic review, they almost reviewed around 10 trials, and they ended up that cytoreductive surgery associated with overall survival advantage. But there are some higher incidence of I mean, there is incidence or there is cost, which the complication for the this approach. If we conducting the upfront, like cytotoxic, you can reach the complication up to 10% in comparison with the 3 to 29% for the deferred approach. That was the retrospective data. Then prospective trials conducted by the European Union and the French group. We can see the aortic group, they conducted the certain trial comparing the immediate cytoreductive surgery versus the deferred one. And they ended up that overall survival was in favor of the deferred one. And we can see that there is with hazard ratio of 0.57, that means those patients who underwent deferred approach, they have better overall survival. And then came the Carmina trial, the French trial, which compared targeted therapy suitent or targeted therapy plus cytoreductive nephrectomy. This trial showed that the use of TKI without nephrectomy, upfront TKI, showed better overall survival. And we can see that in Carmina trial, that most of the benefit and most of the group was found in intermediate to poor risk group. Now, what about using cytoreductive surgery in the era of immunotherapy? If we reviewed all the trials that used immunotherapy, we can see that mostly at least 70% of the cohort of the immunotherapy, they underwent immunotherapy. And by analysis, we can see extrapolation and subgroup analysis, we can see that the cytoreductive nephrectomy was, those underwent were better than those who did not underwent cytoreductive in terms of overall survival. So now we have conflicting data. Data came from the retrospective, which they showed that there is benefit, while the prospective two major trials, they showed that there is no benefit for cytoreductive and maybe detrimental as in Carmina trial. But we have also signal from in the era of the immunotherapy that showed that the cytoreductive patient gained better overall survival. So for that, waiting for the ongoing trials that could answer the question, for the time being, the recommendation is we can tailor-made based on the tumor board decision. So we divide the patient, those patients with favorable risk or intermediate risk with good performance, and if that means fit patient with oligometastasis, and those patients with primary symptomatic, like those with thrombus, we can go for upfront cytoreductive nephrectomy, while those patients with poor risk features by IMDC risk scoring system, poor performance status, high volume metastatic or sarcomatoid features, those patients in need for immediate systemic therapy. So we have to go for upfront systemic therapy, and then we can discuss the deferred cytoreductive nephrectomy later on. When we reviewed the European guidelines, American NCCN guidelines, and European urology guidelines, all of them favoring systemic therapy first in most cases, and reserving surgery for patients with good prognosis, low mutation burden, and good performance status. So this is the last, the final part of my talk, the systemic therapy in metastatic renal cell carcinoma, and we have many prognostic models, maybe 10 models, but the most famous one is the IMDC criteria, which include performance status, time from the initial diagnosis to targeted treatment if less than 1 year, hemoglobin less than 10, lower than the lower limit of the normal, calcium more than 10 milligram per deciliter, platelet count above the upper limit of normal, or neutrophil count more than upper limit of normal, then favorable, consider if zero risk factor, intermediate if 1 to 2 risk factors, poor 3 risk factors, and we can see that this was reflected straightforward on the overall survival. So for favorable risk, we can see in the blue line how good is the overall survival, red the intermediate, green the poor. So it was valid and reflected directly on the overall survival. When we select the systemic therapy for advanced digital carcinoma, many factors we have to consider, and we can see that we have to be to know that till now we don't have predictive biomarker. We tried to use the tumor mutation burden or PDL1 were not valid. And the stratification which we use and adopt is the, as we mentioned, IMDC, favorable, intermediate, and poor. And also the consideration of sarcomatoid pathology is important. We can use immunotherapy. That means dual immune therapy. So please, for our pathologists, don't miss mentioning the subtype sarcomatoid or non-sarcomatoid. Also, when we consider the treatment, we have to consider what the patient, if the patient developed the progression on top of Pembro in the adjuvant setting, that means the patient will be refractory for Pembro or immune therapy in the metastatic setting. And consideration of the patient preferences and the clinical characteristic. Always when we consider the treatment, we have to consider the level of the evidence, the efficacy benefit, availability in our country, and also the safety and tolerability and the impact on the quality of life. Just some pharmacology for our pharma student and for our doctors, that the groups which we use in metastatic renal cell carcinoma, multiple groups. I will give examples for vascular endothelial growth factor inhibitors like sunitinib, bazobanib, exitinib, and cabozantinib, while the other group, mTOR inhibitors like everolimus, temsirolimus, and we have the immune checkpoint inhibitors, which are the immune therapy like nivolumab, Pembro, ipilimumab, and we have the new group, which are hypoxia-inducible factor 2 alpha, HIF2 alpha inhibitor like belzutifan. So what we use in the first line therapy, usually we use combinations. Among the combination immunotherapy to the left side, nivo, ipilimumab. Just, of course, you want to hear what about the response rate. Look to the response rate. It is 39% for the immunotherapy nivo-ipi. For the Pembro immunotherapy with tyrosine kinase in the second column, we may reach up to 61%. So we have also another combination, nivo cabo, 56%, and the best response rate for pembrolizumab, 71%. So whenever we are looking for better response rate, we have to go to the clear protocol, which is pembrolizumab or any tyrosine kinase inhibitor. What about those patients with sarcomatoid features? Those patients may benefit more from the use of immunotherapy. That means dual immune therapy. We can see that there is complete response rate reaching up to 23% complete response in the metastatic setting for the immuno, while for those who received immuno-TKI, it is ranging between 11 to 15% as maximum. What about the second line? If the patient progressed in the first line, we have to consider what the patient received in the previous treatment. So if the patient received immune therapy as before progression, then we have to go to cabozantinib or lenvatinib plus everolimus. If the patient received tyrosine kinase inhibitors, we will use immune therapy. And if the patient has bone metastasis, we should address also the anti-osteoclast medication like denosumab, zoledronic acid. And if the patient has pain or threatening bone mets, we can consider stereotactic radiotherapy. Again, The consideration in the second line depend on the previous treatment received, strength of the evidence, toxicity profile, patient comorbidities, and the patient preferences. As supportive care and surveillance for those patients underwent nephrectomy, we have to do CT scan every 3 to 6 months for 3 years, then annually, usually for 5 years. Those patients under active treatment for metastatic renal cell carcinoma, we monitor them usually every 12 weeks with to assess the response to the treatment. And we have to consider the supportive and palliative care. Sometimes the patient has severe pain, then we send them to radiotherapy, and we have also to be aware about the toxicities of tyrosine kinase inhibitors like hypertension, fatigue, thyroiditis, and others. For immune therapy, we have also the immune phenomena. So thyroid function or hypothyroidism is the commonest. So thyroid function should be done frequently, and looking also for the other immune adverse events. We have many emerging therapies. We have the HIF-2 alpha inhibitors. Now we are using it, belzutifan, for von Hippel-Lindau associated renal cell carcinoma. We have the new T cell engineering, CAR T cell therapy, targeting the CA-IX or other RCC antigens. We have also the new combinations for TKI and immune therapy. My last slide and conclusion, we can say that surgery cures most localized RCC using nephron sparing as the preferred approach. IMD-CIRSC guide model, it will guide our first line therapy, and if the patient has poor risk features, immunotherapy combination is the best. Using sequential treatment, starting with TKI, then immune therapy, or the opposite, will extend the survival in advanced disease. And consideration of genetic testing for hereditary syndromes, especially for young patient, and bilateral RCC is very helpful for selection of the appropriate treatment. Thank you. Wassalamu alaikum wa rahmatullahi wa barakatuh.